All right, so I'm pleased to introduce our moderator for today's session, Molly McCoy. Let's bring Molly up on camera here. So some of you may remember Molly from our last webinar. We hosted one with on documentation, but Molly is a part of our clinical and scientific affairs team. And with over 20 years of experience in the field, she has worked as a clinician, educator, and technical advisor in all settings from independent small practices to level 1 trauma centers, hospitals, and nursing and rehab centers. So Molly, are you there? Let's make sure you're up and good to go.
I'm here. Thank you.
Excellent.
All right.
So,
thank you
Molly,
very much.
passing it to you.
All right. Okay, so thank you for that introduction. I'm super excited to introduce our speakers and our panelists for the discussion at the end here. So let's go ahead and get started. Dr. Branch is with us, Dr. Ben Branch. He is a physical medicine and rehabilitation physician and is board certified. He practices in Portland, Maine, and Dr. Branch serves as the medical director of the Outpatient Rehabilitation Clinic and as program director for the Limb Loss Care Pathway at Maine Medical Center. Hello, Dr. Branch.
Hi, Molly. Thank you.
Yeah. Okay, and let's go ahead and introduce the other folks that are going to be on our panel at the end as well. I'd like to bring up John Ball. He is a clinic manager with Hanger Clinic in Waterville, Maine. John's been practicing as a board-certified prosthetist and orthotist since 2013. Before becoming a prosthetist and orthotist, John worked both as an athletic trainer and a physical therapy assistant. So welcome, John.
Thank you, Molly.
Yeah. All right, and last but not least, Shane Werdeman, PhD and prosthetist, is our Director of Clinical Research at Hanger Clinic. He has been published in numerous studies and peer-reviewed journals. In addition to his research work, he also continues to manage a patient caseload with Hanger Clinic. So welcome, Shane.
Welcome, Molly.
Okay, thank you all very much for joining us today. And we'll see everybody back in just a minute. So with that, I'm going to turn everything over to Dr. Branch, and I will be monitoring the questions that come through that are written in by the folks who have joined us today. And if we have questions that are relevant to what he's speaking about right then, I will go ahead and break in and get those questions out to him. Otherwise, we will continue some of the question and answer in our panelist section at the end of the presentation. So Dr. Branch?
Thank you, Molly. I appreciate that introduction. So as we get ready to discuss expanding opportunities for care and providing care outside the clinic walls, we have a couple of objectives today. So we're going to discuss kind of the current challenges that we face in trying to treat our patients, quite frankly, with various different locations and different diagnoses. We're going to review the utility of telehealth visits and kind of how that can help your practice for those of you who haven't used this technology. We're going to share some ideas to improve that remote patient experience so that we keep it professional but also personable to the patient as well. And we're going to also discuss some ideas to improve the delivery of patient care. So this scenario is probably fairly familiar to many of you. This is a 45-year-old gentleman who underwent a right below knee amputation about 5 weeks ago, we'll say. He's already seen his vascular surgeon. They took out his staples and sutures. He's been cleared for weight bearing and is tolerated. His incision line is well healed. He's seen his prosthetist and established with them, but he's having some distal residual limb pain. He's having some swelling. And unfortunately, he lives about 80 miles away from your clinic, and he's not able to drive currently. So he's in need of a prosthetic and rehabilitation evaluation. He's going to need his orders and get started with therapy, etc. So on the next slide, we'll see some of our challenges that we have when we're trying to deliver care to these patients. You know, some of this is logistical for patients. Patients may be elderly, they may not be able to drive any longer. They may live geographically very distant from a clinic. But in this particular situation, this gentleman, it's a 160-mile round trip for him, and he's got to see multiple practitioners. He's going to need to see his physician. He's seen his vascular surgeon already. He's going to see a physiatrist. He's already seen his prosthetist and probably have several trips there. And then he's ultimately going to need physical therapy. So his time and the logistics are certainly a challenge for us. From a clinical perspective, if we delay his care or we're not able to provide care as quickly as possible for him, we may lose his motivation or we may not be able to capture his engagement, if you will. From a physical standpoint, scar adherence, if he goes too long without providing scar massage, that kind of thing, we can run into difficulties that they can potentially be unreversible. Desensitization and working through those pieces are very helpful. So again, providing care in a timely manner is very helpful. And from a financial standpoint, there's actually an implication upon the system, upon our insurance and payer partners, as well as physicians and patients themselves for, the cost of care to deliver if we delay care, if we don't have care delivered in a timely fashion, if you will. And on the next slide, we'll see a very meaningful study that was published by Shane Werdeman and his team called the Impact Study. And I personally found this very interesting. So if you look at groups A, B, C, and D, the things to note there are, it's roughly a cost of about $100,000 for total care for a unilateral limb below knee amputee. So in that A group, they looked at that cost. If you look at B and C, when we expand that time frame out to about 6 to 9 months, so if the patient didn't receive their prosthesis until 6 to 9 months, that figure bumps up slightly. But the B and C groups are pretty similar. But the interesting thing to note here is the cost to the system, to the patient, to the insurance companies and payer partners for us is the D category. So when it's delayed until 10 to 12 months, there's a substantial increase in money. In fact, if you look back, Group D compared to Group A, it's a double. The impact of that financially is doubled. So there's certainly multiple incentives for us to provide timely care for these patients. And on the next slide. So using telehealth as a way to get outside of our clinic has a lot of different implications to practice. In my practice, it allows simply for more timely delivery of patient care. Patients are able to get visits a bit faster. I'm able to provide visits sometimes after hours or when clinic is already closed. In certain situations, when the scenario calls for that. It allows us to prevent complications through providing more timely care. It certainly allows for us to reach a greater breadth of patients, certainly by geography not really being a barrier. It also allows me to perform an eyes-on skin assessment. So particularly for my diabetic patients, if they call in and they say, there's something wrong with my skin, I'm not quite sure I need to come in, rather than trying to figure that out on the phone or triage it, I can simply join them in a telehealth visit and be able to visualize that and get a better idea of what needs to happen. One of the big benefits of this also is that it allows for the entire rehab care team, or almost the entire rehab care team, to come together. And we'll talk more about the benefits of that later as well. Essentially, we're looking at cost and time savings as well as efficiency. It reduces the number of office visits, it helps with transportation, it reduces convalescence and time to implement prosthetics, and it also reduces overall cost to the system itself. We'll look at kind of breaking down the telehealth visit. We'll look at, opportunities and things that you should think of, or I would recommend you think of before the visit, during the visit, and then after the visit. And on the next slide, for your information before the visit, because this is a telehealth, there's really no waiting room time. So that's something I've seen in my practice, that you really have to be ready to go. If the patient is ready at 1 o'clock, you want to make sure that if you're coordinating amongst offices, that patients and other offices are aware of exact start times. They've done their check-in process ahead of time so that that's not delayed, to keep everyone on schedule. And it also helps with patient expectations, certainly. You want to make sure that you do obtain consent, just like any visit with the patient. You want to make sure that they understand what this experience will be. And if you're billing for it, you want to make sure that they understand what the billing implications are and as it pertains to their insurance. You also want to make sure that you get their consent for whoever else might be within earshot of the camera when you're engaging in these types of activities, so that you can be compliant for HIPAA. You want to make sure that you gather information ahead of time. So diagnostic information, if you have it, progress notes from therapy, or if the prosthetist has already had a chance to see the patient, information from the primary care physician, vascular surgeons, et cetera, so that you have that available at the time of the visit. It just simply makes it more efficient and more productive. You want to make sure that you gather height, weight, and other vitals or testing that you may want prior to the visit. That's always helpful as well. And certainly prior to entering these video chat type conferences, you want to make sure that you go through a technology prerequisites checklist, which for those of you who haven't done this technology before will be very important so you can understand what the patient needs to have or have access to facilitate it. I've found that when these types of visits are hosted by, like in a combined visit with an orthotist or prosthetist office, it really takes the anxiety of the patient, especially if they're elderly, takes that off of them because the technology typically is handled by the staff there. And on the next slide, we'll talk about things during the visit. I think one of the things that's been most impactful to me is really understanding the difference between that human interaction and being in a physical space with someone. Physicians typically perform physical exams themselves and perform their own interviews, and you're simply not going to be able to do that to the same degree that you would because this is outside of your clinic walls. But making sure that you have that time to establish rapport with your patient, understand what their challenges or what their questions may be ahead of time is very important. What I typically will do is I will set aside, say if it's a 30-minute visit, I'll set aside the first 15 minutes so that I can discuss one-on-one with the patient after we've established the connection. The staff will leave, I'll engage with the patient, and then we'll give the office a call and they'll come back in so that we can all join in the second half of the visit as an entire team. You want to make sure that you understand what the patient's questions are up front. That's very helpful so that they feel that it's been productive and that we've accomplished what we needed to on the video chat interaction. You certainly, prosthetists and orthotists can feel free to facilitate the exam. I found that very helpful. I can see what something looks like, but I don't know how that palpates, and they have been very helpful in being able to facilitate that. You want to consider things such as diagnostics that may help your impression. Gait evaluation, gait metrics, volume analysis, etc. And you want to make sure that you engage in the real meat and potatoes of the interaction. One of the strengths of this is really that bedside discussion that we used to have years ago that we can now have with video chat software when we do these combined type visits. Patients eat that up, they love it. So on the next slide rather, after the visit, things that you'll want to make sure that you remember to do is kind of review what was discussed with the patient. Make sure everybody in the room is on the same page. You want to reiterate what the follow-up plan is. You want to enter orders for therapy, order for prosthetics, or whatever you may feel is necessary at the time. You may want to consider an after visit summary as well. That's something that I will use frequently. It's basically the Cliff Notes version of giving a patient the bullet points, if you will, of what we discussed. I will reiterate things on there such as scar massage, skin surveillance, who they're going to have therapy with, when they will follow up with me, etc. You also may consider putting in things such as the Amputee Coalition of America or other resources for peer support or others. And if you tell them up front you're going to do that, it takes some of the pressure off of them from trying to remember or write everything down during the visit. I also would add for physicians in the audience, you want to consider what your threshold would be for an in-person visit, whether it's if a wound degrades or if they have complaints of chest pain or shortness of breath or whatever it may be. What would be your threshold for not using a telehealth visit and really insisting that the patient come see you in the office? There's additional information here. There's several links here that you can look up. These were directly pulled from CMS website and also referencing some of my own experiences. So Molly, at this point, are there any questions out there that anybody has at this point in the presentation?
Yeah, so one thing that did come through was really, and maybe you're going to get to this in just a second, but really someone had asked, how has using telehealth impacted your practice personally, pluses and minuses? I know we're going to talk about that a little in the discussion, but just as a touch point here.
Sure. So, so for me in Maine, there are a number of different prosthetic offices that I have the pleasure to work with, and patients choose who they go to. But because geographically patients and those offices can be so far apart in our state, this has allowed me to be able to connect. It doesn't require the prosthetist to travel to my office for a combined visit or patients to travel to several different visits. It really allows for almost instant access. It cuts down some of those barriers to care. And then on a personal side, the interaction with the team, being able to talk out loud, have those bedside conversations where we discuss meaningful medical comorbidities, and then learning from prosthetists about what types of componentry may help with CHF or COPD, et cetera, has been very helpful to me.
Yeah. I think we have found in working together, it's been interesting that so often we're recognizing that we had all this great interaction around different patients, and we're maybe even missing out on those interactions before we were able to do telehealth as sort of a revisit to team medicine. Like you were talking about having the bedside discussion that you would have gotten during an old-fashioned sort of round, but you can do per visit.
Exactly.
Yeah. Very good. Okay. That's all the questions that I see right now. So we can move to that next section and next slide here. Great. So what I think would be really great is if we go ahead and move into the discussion piece and bring in our panelists, which would be wonderful. So as we're bringing those folks up, I think we'll go ahead and interject any questions that come through from participants as well. But I want to just start out with a discussion, bringing Shane into the discussion here. I know that you're currently participating in a telehealth working group at our organization, and one that discusses the coordination of care between the rehab team through telehealth. And I'm curious if you can discuss a little, kind of building on what we just talked about between Dr. Branch and myself, but if you can discuss a little about the importance of understanding our roles within the care continuum and how that helps sort of implement this type of service.
Sure. Thanks, Molly. Great presentation, Dr. Branch. Very much enjoyed it. Yes, I am fortunate to be a part of a task force right now that is looking at how to implement telehealth within O&P. And, we're really exploring a few different potential pathways. And we have some really excellent team members that are taking that forward to really understand, what is the best model? Is it something similar to like what Dr. Branch is describing, where it appears that the visit is occurring at the prosthetist office, and at that point, then John can be done with the appointment and then transition directly into the prosthetist appointment, where he starts to actually take the mold and move forward. And then we're also looking at, maybe instead it's serving the role of telehealth between the prosthetist versus just the patient. So there's a few different pathways there that we're looking at. I think one of the things that we want to understand is what is the best role of the prosthetist orthotist in that telehealth model. And as we look at that, one of the things that is definitely emerging, Dr. Branch kind of hit on it, was you have the ability to probably even a better potential of getting all team members there. It's getting lost. There's a lot of emphasis on the fact that you have patients having to travel, and that creates burden. It also creates lags when you have to make these multiple appointments. But one of the benefits of this might also be that it can be a challenge sometimes for healthcare team members to actually also travel. So now I think we have an opportunity of more of those cases where it's not just a meeting between the prosthetist and the patient, or the patient and the physiatrist, or physiatrist, patient and PT, but where's the prosthetist, and all of a sudden you can get all the team members involved, and it kind of cuts out on the old classic phone game where people are just trying to relay a message over and over and over, and by the time it gets to the end, you have no idea what's happening. I think there is a really good opportunity. Dr. Branch, last comment I'll say is, he really has an excellent model there, where you're talking about the last point of how many patients are in areas that just don't have access to someone that is trained in a rehab as a rehab specialist. PM&R is a very specific specialty that unfortunately not all individuals have in their backyard. And so this really opens up that opportunity to make sure they're getting proper management. So.
That's such a great point. I think that actually transitions well into, talking about different roles. I know, Dr. Branch, you invited John to be part of this panel today because the two of you have been working together so much on providing patients with care using telehealth, especially patients who experience amputation. And so I'm curious if either of you have some best practices or some, examples that you'd be willing to share in thinking about the journey for those patients now that you're, I know, sort of forced to use telehealth, but also you've maybe found it to be a benefit, at least as much as a drawback as it might have first appeared to be. So.
Yeah, definitely. I mean, it's funny because, earlier this year, we kind of were forced as a medical community to switch to telehealth visits. And, now that we are seeing some patients in person, there are still patients that are preferring telehealth, or maybe as physicians, we prefer that they do that because of medical comorbidities, age, et cetera. And, one of the nice things about this type of technology is really being able to pull from John's expertise and all of us be in the same room on the same page, if you will. Patients love that interaction. I did not, we always have sidebar conversations about patients and their comorbidities as far as how we can best serve them and what types of equipment might be the best for a particular condition. But, a lot of times patients aren't aware of that background, backstage work, if you will. In telehealth, this is happening in live time. And I've been surprised at how lovely, the responses have been very positive as to they love hearing us interact. What is the, when I'm discussing, the impact maybe of their heart failure and John or other prosthetists and I are discussing, how that might be impactful to their activities and what we need to consider in design, build, and componentry. John, you and I had a patient not very long ago who had some difficulties with cervical spine and low back, but also is a new below knee amputee. And, I was mentioning to you some of his spine issues, and we got into a discussion about how we were going to maintain his sagittal balance as far as his walking once we employ a prosthesis. So I'll ask you, I mean, when we were having that conversation, I mean, being able to meet with him, who lives a couple hours away from my clinic and not terribly close to yours, when we were able to do that, what did you find that was helpful, or what was beneficial about that combined visit?
Sure, and thank you for the question. I think the overall greatest thing about this is the collaboration. The three of us were able to have an open discussion similar to what we're doing now. The patient had direct input into what his goals were. He was able to talk about what he wanted from his prosthesis. And it was really helpful for you and I to have a discussion about his core morbidities. I mean, he had multiple traumas from an open pelvic fracture, a total hip replacement, a lot of low back dysfunction, SI joint pain. And we were able to discuss actually implementing an SI belt at that point. But having those conversations really helped me think in my mind and come up with a prosthetic prescription and figure out what type of componentry would best help him. I think that's the main thing there.
Yeah, I think, it was, and I even had questions for you, which happens frequently because I'm constantly learning from the team. But, I said, John, I'm not sure exactly what foot and ankle we need in this situation. Which one's going to provide, a better maintenance of sagittal balance and right in live time, rather than, as Shane was saying, instead of sending, phone calls back and forth or notes back and forth to ask that question, I was able to pose that question to you and we were able to solve it right there in front of the patient right at the same time and very efficiently.
Yeah, it was great.
I think what I heard you guys bring up too that sticks in my head as someone who thinks a lot about documentation and clinical note writing is really when John says, you know, I'm able to hear from you what comorbid conditions are really impactful to this person's use of those devices. What do you feel is happening for this person's overall health that is going to be something I need to take into account in choosing components, or is something that might be helped by use of the device? So that sort of medical necessity discussion, I think, could be so valuable for the prosthetist and orthotist, and really is something that is just really hard to get without that immediate interaction and discussion. So such good points. So transitioning over, or kind of, you know, within that same idea, is really the thought around the importance of outcomes in care. As we're discussing, you know, how much information we can get to start making decisions and setting goals and what have you around rehab, especially for someone with amputation or using a brace. I wanted to ask you, John, sort of, how have you been maybe using outcomes? Does telehealth impact the way you use outcome measures or the way you collect or share data? Is there any interplay there for you?
I haven't had a lot of that, but I think one of the greatest outcomes that I've seen with using the telehealth model that we're talking about today is it increases the time, or decreases the time to fit with a new patient and their prosthesis. Just kind of like Shane's impact study was talked about earlier, the sooner we can get someone in a device, the lower the overall burden is for the healthcare system. It's really amazing and very efficient to be able to conduct one of these telehealth visits with Dr. Branch. I have the patient in my office. I'm also able to complete my evaluation and often a cast and measure. So it's really killing a couple birds with one stone.
That's a good point. Yeah. And perfect transition. Wasn't planned. That was very smooth. So perfect transition to the research side of this discussion, which is great. So I want to come back around to the impact study that Dr. Branch mentioned during the presentation, and also John, you just mentioned here, and how overall costs are impacted by the timing of the receipt of the device. So Dr. Branch did bring up some very valid correlations there. I'd like to hear from you as well, Shane, as far as telehealth, timeliness of patient care, that sort of thing.
Sure. And actually, one of the things I'll add with comments from John was that, you know, part of this telehealth task force that we're working on this, we are actively working to lay out what are the measures that we are going to be monitoring to just be able to get to the endpoint and clearly say, look at this clear benefit when it comes to time to fit. And there's several others, because I would also put in there not just operational efficiencies, but really what we're getting at with impact study, as well as some of these other studies, is the betterment of quality of life for the patient. Recognizing that the longer they're sitting there waiting for that leg, that has negative effects to that patient. So, you know, in terms of your question, I think, you know, you have the benefit of reducing time here with telehealth, which there's plenty of studies before this impact study that talk about the clinical benefits of getting up and getting moving quicker. Now we're talking, there's also clearly a economical benefit. If we can look at the telehealth model where you're now talking about, let's use the example of amputation. You know, the model previously, a person has the amputation, they're discharged, they have to set a follow-up appointment with a physician. Hopefully it's physiatry, PM&R if they're fortunate. Then at that appointment, you have the plan put in place in terms of potentially prosthetic rehabilitation. Then that person schedules the appointment with the prosthetist, goes to the prosthetist office. There might be a lag as they try to get into either the physician or a lag to get into the prosthetist. As a prosthetist, I'm sitting there, I'm doing my assessment. If I'm translating, okay, they want to get this person up on prosthesis. Now, what kind of componentry is best in line with it? Then I'm going to have to take that back, talk with a physiatrist or the physician, and say, okay, do these align with, the person's larger big picture health rehab? Because as the physician, the PM&R, Dr. Branch is really putting everything into the big picture, and I recognize I'm just that small, very specific part of that big picture plan. And I want to make sure that I'm not derailing the whole plan by picking the wrong type of componentry. And then maybe that person, we can take a mold there, but there's also potential that I have to schedule another appointment then for that patient to come back to take the mold and start the process. So when all that is happening in a single telehealth where we're communicating, get done with it, and then we move right into taking a mold, we're potentially collapsing 3 appointments with all that lag time into one single appointment moving forward, and the patient and the entire care team are all on the same page. So I think there's a real opportunity to cut down that time and help these patients have really a better quality of life.
Yeah, that's such a great point. One question that did come through that I think is really important here is someone had asked, I mean, we've talked about sort of the benefits here, and there are a lot of benefits with the telehealth model, especially in the rehab coordination for our types of patients, but also some of the drawbacks probably should be addressed, right? So how especially I'll say to Dr. Branch and John, have you seen any drawbacks in terms of things like eyes on skin checks, or being able to visualize what's happening with the patient in the clinic at any time, and how have you overcome those things if you've seen them?
Yeah, I think, one of the drawbacks is, depending on the webcam that's being used on the other end, the lighting can be difficult. And when you're looking at skin and you're trying to assess how well healed they are, how ready they are for that next step, it can be quite difficult. It's nice to have the prosthetist there to be able to facilitate the exam, as I mentioned, but it's also like I really, I'm used to having my own eyeballs on the skin. I'm used to being able to see that in live time. So some of the things that have been helpful is when the lighting is not sufficient, if you will, is being able to come up with a secure way to either fax, text, or email securely a de-identified photo of that limb and that incision line, if you will. Typically the photos come through much better. But that can certainly be a limiting factor. Obviously, not being able to actually have your hands on a patient when we're so used to doing physical exams can be a little bit of a detriment. And being able to get gait assessments done, if someone else is operating the camera, that's great. But if it's the patient themselves, that proves to be quite difficult.
Yeah, the only issue that I found is operating the camera and getting the exact image that Dr. Branch wants when he needs it. That's a little challenging, but I have the benefit of having the patient in my office.
Right. And has there been, has the learning curve, have you started to overcome that? Have you seen that the more you do these visits, the easier it gets? Or you're kind of, is it around the communication piece of it between the two of you? Or is it still, a little bit challenging? You're still working through it?
I think it's getting easier. I mean, after one visit with Dr. Branch, I kind of get his routine and what he's looking for. He has a lot of questions about limb quality, scar adherence, the shape of the limb, whether it's bulbous or ready to fit. So I think once you know, you have an outline in your head, it's certainly much easier and much more efficient.
Yeah, and I think it's come along pretty nicely. I mean, we're definitely learning as we go. We're getting better. How to do a virtual physical exam was a little challenging for me in the beginning. But working with prosthetists, they've been able to facilitate it beautifully, and it's come across quite nicely. I think our end product is continuing to get better. But I think at the end of the day, patients being able to get into their prosthesis and get through that, initiate that rehab care pathway much sooner is that's what it's all about. And this is just one more avenue to be able to accomplish that. It's been very helpful.
A really good question just came through. Someone asked, how do you make sure that patients who you probably suspect or or have told you they're a little tech challenged are prepared for a telehealth visit? Do you have someone that maybe calls them ahead or sort of walks them through what to do? Or I know for a lot of your visits, in particular for Dr. Branch and John, that you're doing it, you know, in office. At least one of you is in office. But is there any advice that you have for sort of talking to patients ahead of time and getting them prepared for this?
Yeah, I think, you know, and that probably is a little bit more applicable to the patients at home. You know, we do call, you know, my medical assistant will call ahead of time and kind of check them in, so to speak. They'll go through kind of what the process is and kind of what to expect. Make sure that they can actually go ahead and connect. That's kind of going through that prerequisites, technology prerequisites checklist that we mentioned. As far as the in-person visits, I don't know, John. I mean, are you guys doing some type of prep ahead of time? Because patients always seem pretty prepared.
Yeah, usually I'll have the patient come in earlier than your scheduled or scheduled telehealth and give them an outline. You know, touch base with them, get some background information, and then let them know what to expect.
Okay.
So another question that came in was, do you have a sense of what patients aren't liking about telehealth, if anything? I know we kind of addressed, you know, kind of the difficulties on the practitioner side of things, but have you gotten feedback from patients who are having issues?
Yeah, I mean, I definitely have had some patients, you know, I think when they do it, they're really nervous in the beginning. You know, a lot of people have been telehealth adapters and have appreciated it, but I've had some that say, you know, look, that was nice, but I really just want to see you in person. And so I think, you know, again, we're trying to simulate that personal touch. We're trying to simulate that in-office experience. I think there are things that just simply don't come across in video chat that, you know, culturally or what have you, we just really appreciate and miss. So I think, you know, that's been, if I've had negative feedback, it's been that, and it really hasn't been strong negative. It's just been, you know, boy, I'm looking forward to when I can see you again, or boy, I'd really would prefer, you know, maybe the next visit to be in person, if you will.
That makes sense.
Would it be safe to say that we shouldn't view this as a replacement option, but really a potential new option to add to our bag of tools for how we care for these patients, recognizing it's not a one size fits all?
I think that's absolutely the point. I think this is kind of one more tool in the toolbox, so to speak. You know, one more avenue that we can reach patients. I certainly don't see it replacing, but you know, sometimes, I mean, I've rendered care for some patients that live hours from my clinic, and they simply would not be able to be seen if we didn't have this opportunity. So it's been great to be able to reach out to patients like that. It's certainly not ideal in every situation.
And Shane, more along the research side of things, but also with patients in mind, someone was asking, like, have you or do you know of anybody who's been able to discuss with patients things like the impact study and have sort of a way to bring that to the patient's attention, to say, hey, you know, there is some research that says that, you know, there could be that we need to move the rehab process along, or what have you. Do you have a way to discuss that, I guess, is the question, with patients, the findings of the research?
Yeah, so it's a good question. I would say that, you know, the impact study it really does have an economic focus. And if I'm going to put it into the context of a patient, you know, we're in a world where their focus is their care, and it may not necessarily be to save the system money when they're in that position, and that's the reality. So I think probably the bigger focus would be to, if I'm going to talk to them, not necessarily that it saves money, but what does that money translate to, right? It's really the result of less procedures, less need for other services to treat comorbidities that are progressively declining and worsening. And that's how I'm communicating studies that, you know, impact study or many of the other previous studies that weren't able to bring in the economic focus, but were focusing on other aspects, that again, they all seem to point to the same thing. The quicker we can get you up, the better it is for you. And we do have some further work that we're beginning to look at that continues to demonstrate that as well. So.
That's a really good point. Yep. Excellent. Okay. I know that we have had a few questions about billing around telehealth and about different options for software that people are using. I think for this discussion, probably that's a bigger discussion than we have time for in our last few minutes here. I know that we do have a handout that will be coming to folks that's direct from CMS that really gives a lot of guidance around that. Dr. Branch, can you speak to that guidance document from CMS at all? That kind of what's in there and what's useful?
Yeah, absolutely. So I think everyone's probably aware that how this is billed, or the codes particularly, are different because of the COVID pandemic. That CMS on the for more information slide, there's a couple of references there that go directly to CMS, and they walk you through what has changed with regards to the billing and what the requirements are.
Yeah, it's a really useful handout. Definitely, it's actually really in depth and clear, which is refreshing. I think also there have been a couple of questions about what does charting look like for something like this. I will say on the P&O side, I don't believe there's much difference in the way we would document this versus other. But John, I leave that to you to answer in your experience, and then Dr. Branch, how charting might look different for the physician in this case, if at all?
Yeah, it hasn't changed much for me. I just make a notation. There's a drop-down box on my evaluation that specifies that it was a virtual visit. But other than that, it's status quo.
Yeah, and on my end, it's changed a little bit. I mean, there's certainly an attestation that I put in there regarding, obviously obtaining consent to see the patient this way. I do mention who is within earshot, and mention that I had permission to speak with those people in the room or within earshot, if you will. As far as the physical exam, that does change a little bit. Obviously, my exam may be a little bit more abbreviated, or I may be annotating, saying, facilitated by, the prosthetist or whomever. The assessment and plan, the subjective information, actually, if anything, it's probably more complete because I have all the information in front of me. I have the patient for their functional history, and I have the prosthetist who I can ask information of, or questions regarding prosthetic componentry. So it kind of helps me formulate my assessment plan all at once, but the general format's pretty similar.
Well, we've had a lot of great interaction through this. I'm kind of over here. That's why you see me looking away all the time, because I'm looking at the comments coming through and the questions. A lot of great questions and interaction with folks. So we really appreciate that from everybody. At this time, I'm going to turn it over to Lily with these last couple minutes.
Great. Thank you so much, Molly, and to our panelists and speaker for being here with us today. I know you guys are all busy seeing patients and practicing, so we do appreciate your time here.
No, thank you for having me.
Yeah, I'll just say thank you for contributing your time and expertise, Dr. Branch, and Molly and John. It's been a pleasure.
Yeah, likewise. Thank you all.
Yeah, thanks. Just real quick, got a lot of stuff coming through. Fantastic session. Love the whole thing. Very interesting. So again, thank you guys all for the participants that joined us today, and we're really glad it was useful for folks.
Great. Thanks, everyone, and we will see you next time in the classroom. Bye now.